Wouldn't it be incredible to have X-ray vision, to see right inside your arteries and watch your blood flow without any surgery?
Yeah, sounds like something out of a comic book.
It really does. But it might sound like a superpower. But thanks to some pretty clever medical tech, it's actually, well, real.
It is.
Welcome to the deep dive. Today we're venturing into the fascinating world of arterial duplex scanning. Let's just call it DUS for short, okay?
Sounds good. And yeah, we've got some fantastic resources here. We're mainly digging into chapters from what's really the definitive textbook, Rutherford's Vascular Surgery and Endovascular Therapy.
Okay, the big one.
The big one. Our goal today is really to unpack how this non-invasive tool gives us this amazing peek inside our blood vessels and, how crucial it is for understanding and managing arterial disease.
So getting the inside scoop basically on what's happening beneath the surface.
That's exactly it.
Okay, so this DUS thing, it's not just one single trick, is it? It sounds like it's a smart combination of maybe a couple of different ultrasound technologies.
It's exactly right. DUS brings together two powerful ultrasound methods. First, you've got your standard ultrasound, B-mode imaging, they call it.
Okay.
That gives us the anatomical pictures of the arteries themselves, like a black and white snapshot of the vessel structure.
Right, the plumbing.
The plumbing, yeah. Then, layered right on top of that, we have Doppler ultrasound. And that tells us about the speed and direction of the blood flowing within those arteries.
Ah, okay.
So you're getting both the structure and the function all at the same time.
So it's like having both a map of the roads and a live traffic report for our circulatory system.
That's a perfect way to think about it, actually. Yeah. And this isn't some, brand new invention either. Its roots go way back to the 1970s.
70s.
Yeah, thanks to the pioneering work of D. Eugene Strandis Jr. out at the University of Washington. Initially, its main job was looking at the carotid arteries in your neck.
Okay, those are the really important ones, feeding the brain, right?
Precisely. And the early success they had using DUS to see plaque buildup, estimate blockages there,
Yeah.
well, that led to a pretty rapid expansion of its use.
I bet.
By the 80s, it was being used to check out arteries all over the body, arms, legs, even the vessels supplying our abdominal organs.
Mm.
A real game changer, though, was the development of real-time color-encoded Doppler imaging. That made the tests much easier to do and the results way clearer to interpret.
Right.
It's like going from an old basic roadmap to one with, highlighted traffic flow in real time.
Color-encoded Doppler. Okay, that sounds like it takes a lot of the guesswork out. But let's just back up a step. How does this whole system actually work? It's magic. We're talking about basically bouncing sound waves off our blood cells.
In essence, yes. DUS systems use these things called transducers.
Yeah.
And inside them are special piezoelectric crystals.
Piezoelectric. Okay.
These crystals have this really fascinating ability. They turn electrical energy into mechanical energy, which produces ultrasound sound waves way too high for us to hear.
Mm.
And then they do the reverse, too. They convert the returning echoes of those ultrasound waves back into electrical signals.
Huh.
So the same device is acting like a tiny speaker, sending out sound, and a microphone listening for the echoes.
Like a miniature silent sonar system hunting for submarines inside us.
You can definitely think of it that way.
Yeah. Right.
And these transducers, they have multiple tiny elements inside that let the ultrasound beam be focused and steered really precisely.
Okay.
And they've got the resolution needed to image tissues at different depths. Now, for getting a clear picture of arteries near the surface, like in the neck or limbs, we tend to use higher frequency transducers. Think 5 to 12 megahertz range.
Higher frequency. More detail.
Exactly. Higher frequency gives you really fine detail for things closer up.
Yeah.
But for seeing deeper structures like those visceral arteries in the abdomen, or even blood vessels in the brain with transcranial Doppler, we need lower frequencies, generally between 2.5 and 3.5 megahertz.
Why lower for deeper?
It's because the ultrasound signal gets weaker. It attenuates as it travels through tissue, just like any sound, and lower frequencies can simply penetrate further before they fade out.
So higher frequency for sharp close-up pictures, lower frequency to see deeper. Makes sense. And I guess the technology just keeps getting better.
Oh, absolutely. Newer transducers have what's called ultra-wide bandwidth. That allows for techniques like harmonic imaging.
Harmonic imaging.
Yeah, it gives even better resolution and cuts down on some of the image noise or artifacts. They also use dynamic frequency tuning. That's a clever way to optimize the image quality at different depths automatically during the scan. Plus, advances in beamforming technology mean the ultrasound beam can be controlled even more precisely. That's led to things like three-dimensional imaging of blood vessels.
3D views of our arteries without any surgery, that's a pretty incredible leap.
Yeah.
Now, you mentioned B-mode imaging earlier. When we see that grayscale picture, what exactly are we looking at?
Okay, so the B-mode image is made up of thousands of tiny gray dots, pixels. The brightness of each pixel corresponds to how strong the ultrasound echo was that bounced back from that specific spot.
Right.
Stronger echoes, which usually come from denser stuff like the vessel walls themselves or calcified plaque, they show up brighter,
Yeah.
lighter gray or white.
Okay.
So by processing all these returning echoes, the system builds up that 2D picture of the anatomy underneath. And for the best view of the arteries, ideally, you want the ultrasound beam to hit the vessel wall at a right angle, a 90-degree angle.
90 degrees. Why is that so important?
It's particularly important for getting accurate measurements of the vessel diameter and for really assessing any plaque that might be lining the wall. Gives you the truest profile.
Okay, so 90 degrees is the sweet spot for the structural picture. Now, what about the Doppler side? You mentioned color flow and spectral Doppler.
Yeah.
What's the main difference there?
Right. So color flow Doppler gives us that visual map of blood flow over a bigger area. It's like a color overlay on the black and white B-mode image.
The traffic map part.
Exactly, the traffic map. The color bar on the screen tells you the direction usually, like red for flow towards the probe, blue for flow away. And it gives a general sense of the average speed.
Okay.
Spectral Doppler, on the other hand, zooms in. It looks at a very specific point within the vessel, called the sample volume.
Just one tiny spot.
A tiny spot, yeah. And it displays the full range of blood flow speeds happening at that single point over time. So it gives us a much more detailed quantitative look at the flow characteristics right there.
Ah, quantitative. So real numbers.
Real numbers. Think of it like
Okay.
the difference between a weather map showing general wind patterns across the state versus a precise anemometer measuring the exact wind speed right here in this one location.
Okay, so color Doppler gives the big picture, the quick visual overview of flow in a region. Spectral Doppler gives the detailed, precise data for a specific spot we care about.
You got it. Color Doppler is what we call semi-quantitative, gives a general idea. Spectral Doppler provides the hard quantitative data on peak velocities within that small sample volume.
Makes sense.
But for spectral Doppler to give us reliable numbers, the angle is crucial. The angle at which the ultrasound beam hits the blood flow with a pound, the Doppler angle really matters. Ideally, we want that angle to be 60 degrees or less.
60 degrees or less. Why that specific limit?
It's all about the physics, specifically the Doppler equation. This equation connects the change in ultrasound frequency, the Doppler shift, to the speed of the red blood cells. But it also involves the cosine of that Doppler angle.
Ah, trigonometry flashback.
Aha, yeah. What that cosine function means is that as the angle gets bigger, closer to 90 degrees, the Doppler shift becomes much less sensitive to the actual blood velocity.
So small changes in speed don't register as much.
Exactly. And worse, if the angle isn't set accurately by the operator or if it's just too high, you can get significant errors in your velocity measurements. Like a small 5-degree error at a 60-degree angle. That can lead to a 15% error in the calculated speed if the real angle was actually 65 degrees.
Wow, 15% error just from being off by 5 degrees. That really highlights how crucial the technologist's skill is.
Absolutely critical. And when we're using pulse Doppler, that's the type for spectral analysis.
Yeah.
The size and the placement of that sample volume are also key.
Yeah.
Ideally, you want the sample volume relatively small, usually less than a third of the vessel diameter.
Right.
And it needs to be positioned right in the center stream of flow to get the most accurate picture of the blood's velocity.
Right, in the fastest part.
Pretty much, yeah.
Okay, let's really dig into these blood flow imaging techniques now. Color Doppler, we talked about colors meaning direction and hinting at speed. How do we interpret what we're actually seeing on the screen there?
Well, the person doing the scan, the technologist, adjusts several settings, things like the velocity scale, color priority, color gain. They tweak these to make sure normal, healthy arterial flow, what we call laminar flow, looks just right.
Laminar flow, smooth flow.
Smooth flow, yeah. In a healthy artery, it'll look like a consistent color filling the vessel. Maybe some subtle shade changes as the blood speeds up and slows down with the heartbeat, but basically uniform. And to set the color gain right, they'll actually turn it up until they start seeing a little bit of random color speckle, like noise, inside the flow area, and then they back it off just slightly.
Why do they do that?
That ensures that even weak flow signals near the vessel wall are still picked up and displayed. But if the gain is too high, the color starts to sort of bleed outside the actual vessel walls, making the artery look artificially bigger.
Ah, okay. Finding the sweet spot. And what about when those colors seem to wrap around or suddenly change in weird ways? That's the aliasing you mentioned, right?
Yes, exactly. That's color aliasing. It happens when the blood flow speed goes faster than the maximal speed the machine is set up to display accurately.
Too fast for the settings.
Right. There's an upper limit determined by something called the pulse repetition frequency, or the Nyquist limit. When the flow goes above that limit, the color coding essentially wraps around the color bar. You might see what looks like flow going the wrong way or just bizarre color shifts.
How do you fix that?
The examiner can usually correct it by increasing that pulse repetition frequency setting or sometimes by increasing the Doppler angle slightly.
Got it. And how does a stenosis, a narrowing of the artery, show up on color Doppler? What are the visual clues there?
A stenosis creates some pretty characteristic changes you can see. First, you'll see a distinct narrowing of the color-filled flow channel right where the blockage is.
Makes sense.
Second, right within that narrowed bit, you'll often see a jet of very high-speed flow. And this high-speed jet very often shows that color aliasing because the blood is moving so fast.
Okay, the weird colors again?
Yep. And then just downstream, after the stenosis, the flow becomes much more turbulent, much more chaotic. And this turbulence shows up as a mosaic pattern of mixed-up colors within the artery.
A mosaic, like lots of different colors jumbled together.
Exactly. In really bad stenosis, you might even see a very bright, almost whitish, desaturated flow jet right at the tightest spot, followed by that chaotic, multicolored, turbulent flow stretching downstream. Sometimes the vibration from all that turbulence can even create a color artifact outside the vessel, in the surrounding tissue. And that can sometimes correspond to a bruit, a sound a doctor might hear with a stethoscope.
Wow. So narrowing of the color, a high-speed jet with aliasing, and then a chaotic mix of colors further down. Those are the key signs on color Doppler that point to a narrowing.
Those are the big ones, yeah.
Okay. What about power Doppler? How does that give us a different view?
Right, power Doppler, sometimes called color angio. It focuses on the strength or the amplitude of the Doppler signal bouncing back from the red blood cells, not their speed or direction.
Just how strong the echo is.
Exactly. And this makes power Doppler much more sensitive at picking up very slow blood flow or flow in very small vessels. It could be like 3 to 5 times more sensitive than standard color Doppler.
When would that be useful?
It's great for seeing that very faint trickle of flow you might get in a super tight stenosis,
Mm-hmm.
or for imaging really small arteries where the flow signal is weak.
Oh.
The big trade-off is power Doppler gives you zero information about the direction of the flow, and the signal is also less dependent on that crucial Doppler angle.
So it's fantastic for just finding flow when it's barely there, but it doesn't tell you which way it's going.
You got it. Great sensitivity, but no directionality.
And then there's B-flow imaging. That sounded really interesting, seeing blood flow in grayscale.
Yeah, it is pretty cool. B-flow imaging shows the flowing blood itself using shades of gray. So both the blood and the tissues around it are shown in different gray levels.
How does it do that?
It works by specifically amplifying the very weak echoes that come back from the moving red blood cells themselves.
Okay.
It's particularly good for showing the flow right near the vessel wall, the boundary layer, and also the flow patterns around plaque.
Why is that helpful?
Well, because it doesn't rely on the Doppler shift for velocity info, it can be really useful for looking at complex flow patterns, like where bypass grafts connect, or in dialysis access fistulas, places where standard color Doppler can sometimes have artifacts that kind of mess up the picture.
Ah, so it avoids some Doppler problems.
Exactly. B-flow gives us a different kind of visual clue about how the blood cells are moving, which can really complement what we see with color Doppler.
Okay, so we've covered the visual side quite a bit, but spectral analysis seems to be where we get more of the actual numbers, the quantitative data. What does a normal spectral waveform look like? What are we aiming for?
Right. In a normal artery with that smooth laminar flow, the pulsed Doppler spectral waveform shows a relatively narrow band of velocities throughout the heartbeat, the cardiac cycle.
A narrow band, meaning all the blood cells are moving at similar speeds.
Pretty much, yeah. Similar speeds, same direction, not much disruption. That narrow band tells you things are flowing smoothly. However, if the sample volume we're using is too big compared to the vessel size, or if it's positioned too close to the wall, we might see something called spectral broadening. This looks like the waveform gets thicker, vertically. It's because the sample volume is picking up signals from a wider range of speeds. including the slower flow near the edges.
And spectral broadening can also be a sign of trouble in the main flow stream, right? Not just bad technique.
Yes, exactly. When we record the spectral waveform from the center of the flow, spectral broadening can indeed mean disturbed or turbulent flow.
Where do you typically see that?
We commonly see it at arterial bifurcations, where an artery splits flow gets naturally a bit more complex there. Also at points where the artery diameter suddenly changes. And really importantly, right at the site of a stenosis. The narrowing messes up the smooth flow and creates turbulence. Now, it's important to know that the normal look of the spectral waveform actually varies quite a bit depending on which artery we're looking at.
Ah, okay. How so?
Well, for example, in the arteries of our limbs, arms and legs, and also the external carotid artery in the neck, the flow is typically what we call high resistance.
Run resistance.
Yeah. This produces a triphasic or sometimes multiphasic waveform. Think of it as having three distinct parts in each heartbeat.
Triphasic. 3 phases. Like what?
You get a rapid forward flow during the main pump phase of the heart, systole, then a brief reversal of flow in early diastole as the pressure drops, and then usually a smaller forward flow component again in late diastole. Up, down, up.
Up, down, up. Okay, triphasic. That makes sense for higher resistance vessels, like in the limbs. What about arteries that have lower resistance to flow, like going to organs?
Exactly. Arteries supplying organs that need a constant, steady flow, like the internal carotid artery going to the brain, the vertebral arteries, the renal arteries, the kidneys, the celiac, splenic, hepatic arteries in the abdomen.
Yep.
They typically show low resistance flow. The spectral waveforms are usually monophasic,
Monophasic, just one phase.
meaning continuous forward flow throughout the whole heartbeat, no reversal. And the systolic peak tends to be broader, less sharp.
Interesting.
And what's really neat is that changes in the resistance way downstream in the tiny microcirculation vessels are primarily reflected as changes in the diastolic flow velocity part of that spectral waveform.
So the shape of the wave tells you about what's happening further down the line.
To a large extent, yes.
Yeah.
It holds a lot of information.
It's fascinating how much is packed into that little waveform. Now, when we're actually looking at these spectral waveforms, what specific measurements are we pulling out? What are we paying close attention to?
Okay, there are several key parameters we get from the pulsed Doppler spectral waveform that are really crucial for interpretation.
Like what?
We look at the acceleration time. That's how long it takes the velocity to rise from the start of the beat to the peak. The peak systolic velocity itself, the PSV. The end diastolic velocity, EDV, right at the end of the beat. And then there are calculated indices like the pulsatility index, PI, and the resistive index, RI.
Okay, quite a few numbers there. Which one is kind of the main workhorse, the one you rely on most?
The peak systolic velocity, PSV, is probably the most reproducible and the one we use most frequently. It's essential for knowing what normal flow looks like, for spotting critical limb ischemia that's severely reduced blood flow, and really importantly for grading how severe an arterial stenosis is.
And the end diastolic velocity, EDV.
The EDV, measured right at the end of diastole, is often used together with the PSV, especially when we're evaluating really high-grade stenosis, usually ones over 70% narrowed.
Got it. You also mentioned the resistive index, RI. Where is that particularly helpful?
The RI, let's see, the calculation is PSV minus EDV divided by PSV. Clinically, we use it most often to look at the resistance to flow in the kidneys and the brain. A higher RI usually means increased resistance downstream in those organs, which could signal various problems affecting their blood supply.
Okay, kidneys and brain. And what about the pulsatility index, or PI? How's that calculated and used?
The PI calculation is a bit more involved.
Yeah.
It's PSV minus the peak reverse flow velocity, or EDV if there's no reversal, divided by the mean velocity over the whole cycle.
Okay, what does it tell us?
In normal peripheral arteries, like in the legs, the PI is generally greater than 4.0, often even higher further down, like maybe above 8 in the popliteal artery behind the knee.
And if it's a low?
If we see a PI less than 4 in a peripheral artery, it might suggest there's a significant blockage further upstream, closer to the heart.
Ah.
And a change in the PI, or just an overall flattening or damping of the waveform shape, can indicate disease affecting multiple levels of the arteries. We can even calculate a damping factor. Divide the PI in a distal artery by the PI in a proximal one. Normally it's 0.9 or higher. Below that suggests a significant blockage between those points.
So the PI gives an idea of how much the pulse is getting smoothed out as blood travels further away.
That's a great way to think about it, yeah. The damping of the pulse.
And finally, you mentioned systolic acceleration time. How does that help diagnose problems?
Right. The acceleration time is just how long it takes the velocity to get from zero at the start of systole up to its peak speed. Normally, it's pretty quick, less than 133 milliseconds in the legs.
And if it's slow?
If there's a significant blockage upstream, it takes longer for the blood to accelerate. So you get a prolonged acceleration time, often over 200 milliseconds. And the waveform shape looks rounded on the upstroke. We call that tardus parvis, slow rise, small peak.
Tardus parvis, got it.
It's a useful sign of proximal blockages, though things like heart conditions can sometimes affect it too. But downstream blockages generally don't mess up its usefulness for proximal disease.
Okay, so now we're armed with all these different measurements and ways to look at blood flow, but like any test, I'm guessing arterial duplex isn't perfect. What are some common artifacts or errors that can crop up?
You're absolutely right. No test is perfect. There are several artifacts and potential errors. For example, you can get mirror image artifacts.
Seeing double.
Kind of. A strong reflector in the body makes the ultrasound bounce back and forth, creating a duplicate image of a vessel or flow where it shouldn't be. Shadowing is another big one. You see a dark area blocking the view deeper, often caused by heavy calcification in a vessel wall. The calcium just blocks the sound waves.
Like a bone shadow on an X-ray.
Similar idea, yeah. Refraction, the bending of the ultrasound beam as it passes through different tissues, can also cause misplacement of the image or the Doppler sample volume. And like we talked about, aliasing in both spectral and color Doppler can mess up your interpretation if you're not careful.
Those sound like issues with the physics or the body itself. But you also mentioned errors can come from the person doing the test.
Yes, and studies using artificial flow models have actually shown these operator-dependent errors can be quite significant.
Really? Like what?
Inaccurate setting of that Doppler angle is a major source of error in measuring PSV. Getting that angle wrong is a big deal.
We saw that with the 15% error example.
Exactly. Also, if the sample volume isn't placed right in the center of flow, or if the Doppler gain is set wrong too high or too low, the velocity measurements won't be accurate, and the waveform can look distorted. Even if the angle looks right on the screen, if the sample volume isn't truly aligned with the flow direction, the velocity will be underestimated.
What about some of those other technical sounding artifacts? Crosstalk, ghosting.
Yeah. Crosstalk is a specific mirror image artifact only in Doppler. You see the same waveform shape both above and below the baseline. Usually happens if the receiver gain is way too high or if the Doppler angle is near that 90-degree mark we try to avoid for Doppler.
Okay. And ghosting.
Ghosting is a color Doppler artifact. You see these brief flashes of color in the tissues around a vessel, usually caused by low-velocity motion, often just the vessel walls pulsing. We can usually get rid of it by adjusting the wall filter setting on the machine, which filters out those very slow signals.
So it really, really underscores the importance of having a skilled, experienced technologist running the scan to minimize all these potential issues.
Absolutely. And even with a top-notch operator, there can still be some variability in the diagnostic criteria used between different vascular labs.
How come?
It can come down to differences in exactly how they define stenosis percentage, the specific ultrasound machines they use, even subtle differences in scanning technique. Plus, you have to consider patient factors too. Gender, overall physiological state. These can influence findings. For example, studies show carotid PSVs tend to be about 10% higher in women than men.
Interesting.
And conditions like heart failure, arrhythmias, even having mechanical heart support, those can affect cardiac output, and therefore the PSVs we measure everywhere else.
Wow, lots of variables. So how do you try to minimize these errors and get the most accurate picture possible given all that?
Well, making sure that sample volume cursor is accurately aligned with the flow direction is absolutely critical. Like we said, small angle errors mean big velocity errors.
Right.
And it's important to remember blood flow isn't always perfectly parallel to the vessel walls, especially in curvy arteries or just downstream from an uneven stenosis. Getting a precise sample placement can be tricky there.
So what's the bottom line for measurement?
Ultimately, when you're grading a stenosis, the most accurate PSV measurement comes from right within the narrowest part of that narrowing. The technologist has to hunt for that spot and get the sample volume right there. That gives the most reliable and reproducible result.
Okay, got it. Find the tightest spot. So we have a good handle now on how DUS works, what it measures, some pitfalls. Let's talk about using this info to classify how narrow an artery is the idea of arterial stenosis. When does a narrowing become significant?
Right. A significant or critical arterial stenosis is generally one that causes a noticeable drop in blood pressure across the narrowing, typically more than a 15 millimole G drop at rest, and reduces the overall blood flow volume.
Okay.
In peripheral arteries, like in the legs, this usually corresponds to a stenosis that's reduced the artery's diameter by 50% or more,
Huh.
or its cross-sectional area by over 75%.
50% diameter reduction seems to be a key threshold.
It is. Because these significant narrowings cause a major loss of energy in the blood flow, mainly due to turbulence kicking in. Turbulent flow is just much less efficient, much more energy draining than smooth laminar flow.
Ah, so the turbulence itself is a problem.
It signifies a problem, yeah.
Yeah.
So a big part of DUS is understanding not just the physical narrowing, but how much it's messing up the flow hemodynamics.
So DUS helps estimate not just how much smaller the pipe is, but how that's actually affecting the flow through it. That's a really important distinction.
Precisely. By measuring how the blood speed changes as it goes into, through, and out of a stenosis, DUS gives us a non-invasive estimate of that hemodynamic significance.
Okay.
And it can help predict the degree of diameter reduction within certain ranges, like, 49%, 50, 79%, maybe over 80% narrowed. But it's important to know the relationship isn't linear,
Meaning?
meaning the velocity doesn't just double when the diameter halves.
Yeah.
Especially above 50% stenosis, the velocity tends to increase much more dramatically as the stenosis gets tighter and tighter.
Okay, it accelerates faster at higher degrees of narrowing. What are the specific things we look for on DUS that scream stenosis greater than 50%? The telltale signs.
The characteristic DUS features for over 50% stenosis include seeing that elevated peak systolic velocity, PSV, right at the narrowing compared to the healthy segment just upstream.
The velocity jump.
The velocity jump, exactly.
Yeah.
We'll often see that mosaic pattern on color Doppler showing the turbulence.
Right.
And on the pulse Doppler spectral waveform, we'll usually see spectral broadening, sometimes even seeing flow going both forwards and backwards at the same time. During systole, another sign of that chaotic post-stenotic turbulence.
And how do we take those clues and grade the severity beyond 50%? How do we know if it's, say, 70% versus 50%?
The ratio of the PSV, measured right at the stenosis to the PSV, measured in the normal segment just before it, that's the velocity ratio, or VR, is really useful here.
Okay, the VR.
Our VR greater than 2 typically suggests over 50% diameter reduction. If the VR is greater than 4, that's a strong indicator the stenosis is likely over 70% narrowed.
4 times the upstream velocity means probably over 70%.
Generally, yes. And a stenosis that's really significantly reducing pressure and flow often has a VR over 3.5, a PSV at the stenosis maybe over 250, 300 centimeters, and an elevated end diastolic velocity, EDV2, maybe 40 centimeters or higher.
What about the flow further downstream from a significant blockage? What changes would we expect there on the DUS?
Downstream from a significant pressure-reducing stenosis, the spectral waveform often looks damped.
Damped.
Yeah, the sharp systolic peak gets blunted, rounded. The waveform tends to become more monophasic. It loses that brief flow reversal we see in normal triphasic peripheral waveforms.
Okay.
We'd also expect to see that prolonged systolic acceleration time we talked about, and the overall PSV downstream will likely be lower than normal.
And what about really, really severe stenosis, like almost completely blocked, just a trickle getting through? What does DUS show then?
As it gets super tight, say over 90% diameter reduction, the actual volume of blood squeezing through is tiny. Interestingly, the PSV, right at such a tight spot, might only be minimally elevated, maybe only 100, 200 centimeters.
Not super high, like in moderate stenosis?
No, because there's just not much flow getting through to accelerate. And downstream, you might only detect a very low velocity trickle flow, often less than 10 centimeters. Can be hard to even find sometimes.
Wow.
And it's worth noting, too, the plaque in these 50% stenosis is often irregular, maybe calcified. The calcium can cast shadows, making it hard to directly measure the remaining opening. That's a big reason why PSV and VR are our best non-invasive predictors of severity compared to trying to measure the diameter directly on ultrasound.
It sounds like there can still be some slight differences in exactly what PSV values match a certain percentage narrowing, maybe depending on the lab or patient.
That's a very valid point. Studies comparing DUS to angiography, the gold standard, have indeed reported slightly different PSV thresholds for, say, a 50% stenosis.
Why the variation?
Well, the variation, often around plus or minus 15%, can be related to the specific ultrasound machine used. Subtle differences in technique, like how the operator judges the angle or places the sample volume. It's biology. There's always some variability.
So how do labs deal with that?
To account for this, it's often recommended that labs report stenosis severity as a range like 50-70% or 70-90%, rather than trying to pin down an exact single percentage.
Okay, ranges make sense.
And really importantly, each vascular lab should do its own ongoing quality assurance, comparing their DUS interpretations regularly with angiography results to make sure their criteria are accurate for their setup and techniques. It's like ongoing calibration.
That makes perfect sense, local calibration, to keep things accurate. So now we understand what DUS is, how it works, how we interpret it. When is it actually used in patient care? What are the situations where doctors reach for DUS?
Right. Arterial duplex is really versatile. You can
Big.
do it with a portable machine right at the bedside, or patients can come to a dedicated vascular lab. Ideally, for best results, the patient lies comfortably supine on an adjustable table. We want a quiet, warm room, helps keep vessels from constricting.
Makes sense.
For looking at abdominal arteries, it's usually best if the patient has fasted for at least 4 hours. Morning exams are often preferred to minimize bowel gas interference.
Gas can block the view.
It definitely can. Sometimes, if we suspect issues with gut blood flow after eating, we might even need a scan before and after a meal.
Interesting. And how long does a typical exam take?
Usually somewhere between 30 and 60 minutes, depends on what exactly we need to look at. And patients should avoid smoking for at least an hour beforehand. Nicotine constricts vessels.
Good tip. You mentioned earlier DUS is an extension of the clinical assessment. How does it fit into the big picture?
Yeah, duplex testing really serves to either confirm or rule out arterial disease that a doctor might suspect based on symptoms and physical exam, and determine how bad it is. Over the years, lots of studies have compared DUS to other imaging, like CT angiography, CTA, and MR angiography, MRA, before surgery or interventions. The goal has often been to reduce the need for traditional invasive contrast arteriography.
Use DUS instead of the invasive angiogram.
Often, yes. In current practice, contrast imaging is often saved mainly for actually guiding the intervention itself. DUS can frequently give us enough info to decide if an intervention is needed and plan the approach without needing a diagnostic cath first.
So it helps plan treatment.
Definitely. In peripheral artery disease in the legs, for instance, DUS is invaluable for pinpointing blockages or aneurysms, seeing how long they are crucial info for planning the best treatment.
So it's like creating a detailed roadmap for the surgeons or interventionalists. What are some specific clinical situations where DUS is indicated?
Oh, it's a real workhorse.
Mm.
For patients with symptoms of chronic peripheral artery disease like claudication leg pain with walking, it helps diagnose and assess severity. It's absolutely critical in suspected acute limb ischemia, sudden severe blockage. Need a diagnosis fast there.
Right.
If a patient has a foot infection but no pulse, DUS checks for underlying artery disease. We use it for suspected atheroemboli, bits of plaque breaking off, or thromboemboli clots traveling, and really importantly, for routine surveillance after revascularization procedures.
Keeping an eye on bypasses or stents.
Exactly. Making sure the fix is still working.
So it covers diagnosis right through to follow up. When you're doing a DUS exam on the legs, what does that typically involve? What are you scanning?
The extent depends on why we're doing the test. Sometimes just screening for aneurysms or tibial calcification. For claudication symptoms, we typically scan proximal to distal, start high up and work down.
Okay.
We carefully note artery diameter, look at the walls, any plaque, check for clots, and record those velocity spectral waveforms at different spots. Can be upper or lower limbs.
What about a standard lower limb exam?
Usually start with the aorta and iliacs in the pelvis. Use the lower frequency probe, maybe 3 to 5 megahertz. Look for aneurysms, big blockages. Check the common femoral arteries in the groin for that normal triphasic waveform.
Right.
Then moving down the leg from the groin, switch to a higher frequency probe, maybe 5, 7 megahertz, for better detail in the superficial femoral, popliteal, and tibial arteries down to the ankle.
And when you're scanning these lower limb arteries, what specific data are you routinely recording?
We record PSV and EDV in all the arteries we look at. And importantly, we often calculate those PSV ratios, comparing velocity at a narrowed spot to a healthy spot just upstream.
The VR again?
Yep. All these findings, anatomy, velocities, ratios get recorded, usually on a schematic diagram like a map of the leg arteries.
Like your own little arteriogram.
Kind of, yeah. Noting where any aneurysms or stenoses are, the velocity numbers at normal and disease spots. There are also established normal values for diameter and PSV in healthy legs, for reference. And this duplex mapping info can be used to classify the disease severity using the TASC guidelines, A through D categories, based on lesion characteristics, which helps guide treatment choices.
So a really comprehensive assessment, structure plus function. Now, let's zoom in on interpreting findings specifically in the peripheral arteries of the legs. Are there established, universally agreed upon criteria for grading stenosis severity based purely on DUS?
That's a good question. And interestingly, no, there isn't one single consensus set of recommendations for grading lower extremity stenosis severity just from duplex data.
Really? So what do people use?
Well, a set of velocity-based criteria proposed by Cosman and colleagues way back in 1989 have become very widely used as a guideline.
The Cosman criteria.
Yeah, these often involve calculating that velocity ratio, VR-PSV, at the stenosis divided by PSV just upstream. The pulsatility index, PI, gives extra info about downstream resistance, but is not typically used alone for grading the stenosis itself.
We touched on the ankle brachial index, ABI, earlier. How do DUS findings typically correlate with ABI values? Is there a pattern?
Yes, there's a fairly classic pattern as PAD gets worse. We typically see the ABI value go down, the PSV is measured by DUS, and the leg arteries go down, and the PI goes down. They deteriorate together.
Lower ABI usually means lower velocities and less pulsatile flow on DUS.
That's the general trend, yeah. And based on those duplex criteria, primarily PSV, EDV, and that VR calculated across the stenosis found on color Doppler, we categorize the severity.
So how do those criteria break down?
For example, a doubling of PSV to over 150 centimeters, giving a VR over 2, typically indicates a stenosis of 50% or more diameter reduction.
Okay, VR2 means 50%.
Right. For critical flow-limiting stenosis, criteria might include losing that triphasic waveform, spectral broadening, PSV maybe over 200 centimeters, EDV above 0, and a VR over 3.
And for even tighter ones, like over 75%.
For those higher grades, we often see EDV climb over 100 centimeters and the VR go above 4.
How accurate is DUS for these leg stenosis compared to other methods like angiography?
Pretty good, actually. One study comparing DUS to MRA, using angiography as the reference, found a PSV ratio over 2.5 has 76% sensitivity, 93% specificity, 89% accuracy for significant stenosis.
Not bad.
Another big review comparing DUS to MRA and CTA for 50% stenosis found DUS had a median sensitivity of 88%, specificity 96%. And there's excellent agreement shown between DS and CTA specifically for SFA segments after treatment. So yeah, holds up well.
Good to know it's reliable non-invasively. Now, what about the iliac arteries higher up in the pelvis? Is assessing them different?
Yes, the iliacs can be tricky. We can try to image them directly or assess them indirectly by looking at the waveform and velocities down in the common femoral artery in the groin.
Why indirectly?
Direct imaging can be tough due to body size, vessels being twisty, and their depth often needs lower frequency abdominal probes.
So sometimes you infer what's happening upstream based on the femoral artery.
Exactly. When we can image them directly, we look for velocity criteria. PSV 200 centimeters or VREL 2.5 suggests 50% stenosis.
And for 75%?
Maybe VR 5.0. EDV 40 centimeters. A PSVR 400 centimeters is a strong indicator too.
And the indirect signs in the femoral.
Significantly reduced common femoral velocity, say below 45 centimeters, combined with a monophasic waveform that's nearly 90% accurate for a significant blockage up in the iliac, even if you can't see it well directly.
Wow, that's powerful.
Yeah, and interestingly, normal common femoral velocities don't seem to differ much between men and women, or even if there's disease elsewhere, so it's a pretty reliable indirect marker.
How accurate are these direct and indirect methods overall for iliac disease?
For direct imaging, PSV 200, 50% stenosis, has high sensitivity, 95%, but lower specificity, 55%. For 75% stenosis, EDV 40 has 70% sensitivity, 90% specificity. VR 5.0 has 65% sensitivity, 91% specificity.
Okay, and indirect.
Indirectly, just an abnormal common femoral waveform, mono-biphasic instead of triphasic. It's very good, 92% accuracy at distinguishing 50% from 50% iliac stenosis. And low femoral PSV, 45 centimeters, plus a monophasic wave accurately predicts 50% stenosis or occlusion, 88% accuracy. So even indirect clues are very useful.
Let's move down the leg now. Femoral popliteal segment thigh and behind the knee, and then the tibial arteries in the lower leg. How reliable is DUS there?
Generally pretty good agreement between DUS and angiography in the fem-pop segment, especially above the knee, using VR2 for 50% stenosis.
But less reliable elsewhere.
Yeah, correlation tends to be weaker in specific spots, like the profunda femoral artery, the tibioperoneal trunk where tibial arteries branch, and the peroneal and other small crural arteries.
So stick to combined criteria.
Often recommended, yeah. Like PSV 200 centimeters and VR2 to better predict 70% fempop stenosis.
What are the accuracy numbers like there?
Using VR 2.4 for 50% femoral stenosis gives about 81% sensitivity, 93% specificity. Combining criteria for 70% stenosis gets about 79% sensitivity, very high 99% specificity.
And the tibials, the really small ones.
In the tibial arteries, the largest study for 50% stenosis found 88% sensitivity, 75% specificity compared to angiography. So good agreement in bigger thigh upper calf arteries. Gets a bit less reliable further down.
Okay, so generally reliable, but with some challenging spots. What are the overall limitations we need to keep in mind with peripheral arterial DUS?
We've touched on some. Arterial segment. Body size can be limiting. Infrainguinal. A bad blockage upstream can falsely lower downstream velocities, making you underestimate a second blockage. VR might be better then.
All right.
It's also possible to mistake a really tight stenosis for a complete occlusion if there's good collateral flow nearby, confusing the picture.
Ah, the collaterals hide the main channel flow.
Sometimes, yeah. Incomplete imaging can happen if the patient can't cooperate or if heavy calcium shadowing blocks the view.
And specific tricky spots.
Proximal external iliac, internal iliac origin, tabioperoneal trunk are classically tough, and heavy calcification in tibial arteries can definitely affect velocity accuracy.
What about stents? Do they affect readings?
There's been debate whether stents falsely raise PSV by making the wall stiffer, but some recent lab studies suggest the velocity profiles might actually be pretty similar in stented versus non-stented vessels. Still an area of study.
Okay, so strengths and limitations. Now let's shift gears again. DUS for surveillance, keeping an eye on things after interventions like bypass grafts and endovascular procedures. Why is this important, and how is DUS used here?
Right, surveillance after lower limb revascularization, bypass, or endo is really about catching early signs that the graft or treated artery is starting to fail.
Catching problems early.
Exactly. If we can spot narrowing or blockage early, we can often intervene before it totally fails, like thrombosis. This proactive approach can potentially really improve the long-term success, the patency of these fixes.
Let's start with vein grafts, commonly used in bypass surgery. Is routine DUS surveillance recommended after they're put in?
That's actually a bit controversial. I mean, most guidelines agree some surveillance is good, but exactly how much, and specifically whether it must include routine duplex, is still debated.
What do current recommendations say?
Often suggest a baseline DUS within 30 days post-op, then maybe 6-month intervals for a year, then annually. But earlier guidelines sometimes just said physical exam and ABI were enough.
Conflicting advice.
Yeah, but more recent evidence seems to lean towards rigorous duplex surveillance improving outcomes, especially for higher-risk bypasses. A good program should aim for less than 3% annual graft failure.
And DUS helps achieve that.
It can. DUS surveillance finds that a significant chunk, maybe 20%, of infrainguinal vein bypasses will develop a problem, either missed initially or new within the first year.
So it catches things exam ABI might miss. How is DUS surveillance of a vein graft actually done? What are you looking at?
Technique is similar to native arteries. B-mode for graft structure, color Doppler for overall flow, pulse Doppler for velocity spectra at key points, inflow artery, the graft itself, outflow artery.
Looking for specific problems.
B-mode can sometimes spot early technical issues like retained vein valves or bad vein segments. We map the whole graft length with pulse Doppler, recording PSV, EDV, calculating VR, comparing graft to native vessels, and carefully document any narrowings, location, length, diameter change.
And how do you use those measurements to decide if there's a problem needing attention? What are the thresholds?
We use a combo of ABI, PSV within the graft, and VR to put patients into risk categories for graft failure.
Okay, like what?
For example, PSV 180 centimeters with VRU 2.0, but no big ABI drop, often correlates with about 50% stenosis. A more critical high-risk stenosis might show PSV 300 centimeters, VR 3.5, and an ABI drop of 0.15.
And those high-risk ones need fixing.
Generally, yes. Lesions meeting criteria for high-grade stenosis, typically 70% diameter reduction, often PSV 300, EDV 20, VR 3.5, should usually be considered for repair. If left alone, about 25% of those thrombose.
You mentioned risk stratification. Are there different categories you use?
Yeah, usually 4 categories guide management. Category I is highest risk.
Yeah.
Significant stenosis causing low flow, PSV 45 centimeters, maybe weird flow pattern. Big ABI drop, 0.15. Very high thrombosis risk. Needs prompt repair, often within days.
Okay, category 1 is urgent.
Category 2 is also high-grade stenosis, PSV 300, VR 3.5. But flow might still be okay. ABI drop 0.15. Also usually repaired, but can often be elective within weeks. Category 3 is moderate stenosis, PSV 180, 300, VR 3.5, normal flow, minimal ABI change. Often watch closely with serial scans every 4-6 weeks to see if it worsens.
Watch and wait.
Exactly. And category 4 is low risk, graft normal or 50% stenosis with good flow. But T, even here, if overall graft flow velocity is very low, say 40 centimeters, that's the thrombosis risk. Might consider anticoagulation then.
That seems like a very systematic approach. What have been the overall results of using DUS surveillance for vein grafts? Has it made a difference?
Generally, yes. Contemporary results show pretty good primary assisted patency rates, keeping the graft open with surveillance-guided interventions, often over 80% in 1 year.
So it helps keep grafts open longer.
Evidence suggests interventions based on DUS criteria do improve long-term patency and reduce major failures.
Yeah.
However, some researchers question the cost-effectiveness, noting many interventions are still triggered by symptoms, not just DUS. And randomized trials comparing example-I alone versus adding DUS have had mixed results. A big recent meta-analysis didn't show a clear benefit for routine DUS on overall patency, though study quality was sometimes low.
So the jury's still out a bit?
Somewhat. But the Society for Vascular Surgery still considers DUS reasonable after vein bypass due to low cost risk and potential to find fixable lesions, especially early on.
What about prosthetic grafts, the synthetic ones? Is surveillance different there?
Yes, surveillance for prosthetic grafts is less strongly supported by evidence. Some guidelines suggest baseline and maybe 6-month surveillance, example-by plus guide DUS, but it's not as universally endorsed as for vein.
Are there specific DUS signs for prosthetic graft problems?
Some criteria exist for femoral bypasses, like high inflow PSV plus low mid-graft velocity. Some studies suggest intervening based on duplex improves assisted patency.
But maybe used differently.
Yeah, DUS for prosthetic grafts might be more useful as a predictor of thrombosis, especially when mid-graft velocity drops really low, often below 45 centimeters.
Low flow predicts clotting.
Exactly. And in those low-flow cases, prophylactic warfarin might help keep the graft open. Some even suggest warfarin if mean graft velocity is 60 centimeters. So maybe more focused on identifying low-flow risk.
Okay, different focus for different graft types. What about after peripheral endovascular interventions, angioplasty, or stenting? Is DUS used for follow-up there?
Yes, current guidelines generally do recommend routine surveillance after these percutaneous peripheral interventions. DUS is increasingly important here for deciding when a patient might need a repeat procedure to keep things open long-term.
Are there specific velocity thresholds suggesting restenosis after endo treatment?
Yes, several studies have proposed criteria found through experience suggesting a lesion needs reintervention. Often involves PSV above a certain level, maybe 250, 300 centimeters, combined with a VR of 2.5 to 3.0 or higher across the treated spot, suggests significant restenosis.
What about specifically in the femoropopliteal arteries, often treated with stents? Is routine DUS surveillance beneficial there?
Growing evidence suggests it is. Some studies report very high primary assisted patency when DUS criteria guide reintervention for instant narrowing.
So intervening based on DUS helps.
Seems so. And they found limbs with abnormal DUS findings that weren't treated had higher rates of stent occlusion later. DUS after procedures for critical limb ischemia has also shown value. Bad DUS findings predict higher amputation risk.
But maybe not always necessary to intervene.
Right. Other research suggests asymptomatic patients with mild-moderate in-stent restenosis on DUS might progress slowly, suggesting observation might be safe sometimes. So the exact utility of routine surveillance here still needs more high-quality data on patency and patient outcomes.
And interventions in the tibial arteries, way down in the calf, is DUS surveillance practical there?
It's technically challenging, those small deep vessels, but it has been used successfully in some centers after tibial interventions, especially for critical limb ischemia.
Are there criteria?
Criteria for tibial restenosis have been proposed, often PSV 300 centimeters, VR 3.0, but often the decision to reintervene there is driven more by symptoms and wound healing than just the duplex numbers.
Finally, what about after interventions in the iliac arteries, up in the pelvis? Is DUS common for surveillance there?
The role seems more limited there. Studies report fairly low rates of iliac stent thrombosis or need for reintervention.
So maybe not needed as much?
Possibly. Some researchers found many iliac stents that failed actually looked normal on recent surveillance DUS. So some experts actually discourage routine DUS for iliac endo reconstructions, questioning its efficiency.
Well, this has been an absolutely fascinating and incredibly thorough deep dive into arterial duplex scanning. It's truly remarkable how this non-invasive tech gives us such a detailed window into our vascular system.
Absolutely. We've covered a huge amount today. From the basics of how DUS works, to different imaging and Doppler modes, to the key measurements, the potential pitfalls, and its really crucial role in diagnosing and managing arterial disease all over the body, plus its role in surveillance after interventions.
It really is surprising just how much detail and accuracy we can get with ultrasound, basically seeing inside arteries without invasive procedures.
It is quite remarkable, and it really makes you think. Given these continuous advances in non-invasive imaging like DUS, how might our understanding and treatment of vascular diseases keep evolving? Could we see an even bigger shift away from more invasive diagnostic and therapeutic approaches in the future?
A great question to ponder. Definitely an exciting field to watch.